talk to you as well to give just a general feel of what we think PCD and ENT is about, and actually I'd be quite interested in your thoughts and how much interactions you actually have with us in ENT. There are 6 of us working across there for this in Glasgow, and I don't know how often you come across ENT people, and maybe you think we should have done sooner, or we should have done something about it sooner. So this is actually taken from a poster that was done by one of my colleagues quite a few years ago, just looking at general conditions, genetic conditions, and how they apply to an ENT surgeon. And the title there says it really, it's hidden genetic disorders that may present to an ENT person. And the tagline really from it was that early diagnosis makes a massive difference, and we as ENT people are often the first person to see these children, and we need to actually be aware of it, because if it's not on our radar, then we're not able to perhaps get you to, we're not necessarily the appropriate people to treat those conditions from the offset, but we can move you into the right directions. Perhaps people like my colleagues and Benny sitting there at the back. So that little poster presentation, this is the bit that they had on PCD. It's not really to read all of that, but the red bits there, chronic rhinosinusitis and hearing problems. That's bread and butter ENT, that's what we should be dealing with all of the time. So if that is something that is a factor in PCD, then yes, we should be seeing you guys and deciding where the treatment's required or where the advice is required. It's not always treatment. And again, here, PCD should be managed in a multidisciplinary team in a specialist centre. Those are kind of things that are up for discussions, because how much input should you have from an ENT person regularly if actually your child doesn't have an ENT problem, because not everyone will have an ENT problem that needs treating. So this is not about going into all the bits and pieces with PCD, but it's really the middle bit. Okay, so you have wonderful respiratory people and physiotherapists that you will be, your children will be dealing with in terms of the lung function, the lung capacity, all your exercises, all the stuff that you have to be involved with. We're kind of in the middle there, the mucus obstruction. Your body naturally produces a lot of mucus. There's always mucus in the head and ear, nose, throat. It's that for a reason, because the mucus circulates in those areas. And when you get sumps of mucus collecting and your body can't clear it, that's when you get problems with infections, inflammation, whether bugs get into that mix or not. You've got all the stuff there that needs cleared, and then the infection that can happen on top of it. And we're the sort of the upper airway component of PCD, and I think, unfortunately, and probably us as a speciality rather than you as patients, carers, and family members, we need to be more aware of the upper airway sort of things that are going on, I think, because the lower airway stuff gets talked about and managed more often, I think. So the two main things that I'm going to sort of concentrate on are the ear things, okay, so hearing problems and infections, and the ear stuff, which is a blocked runny nose and polyps. As I say, this is kind of bread and butter ENT. This is for me, childhood ENT. I purely do children's ENT, so this is an awful lot of what I see. Apart from my specialist work, this is every other child that comes into my clinic. I would argue probably does have a runny nose, maybe a hearing problem, or an ear infection. They all go to nursery, school, life is a bugfest, and these are the problems that you get. There are problems that come about purely because you get seen by an ENT specialist. Okay, you have respiratory physicians. They're physicians by nature, wonderful people that will take a holistic approach and deal with lots of factors to do with patients. And ENT specialists are predominantly ENT surgeons. And surgeons can sometimes be, and that's the right thing to do for the right child, for the right procedure, the right condition, but it's not always the right thing to do. And I think that's the problem sometimes when we get pushed towards ENT, is that we might be. And there are surgical solutions that work really, really well. So if you have a hearing problem, and arguably for infections as well to do with the ear, then ventilation tubes or grommets work well for lots of children. If you have a blocked runny nose, polyps, although that's rare in children, full stop. It's also very, very rare in PCD. But we do have a surgical solution for that. We have endoscopic sinus surgery. That's a bit more complicated, but it's sinus surgery, and it's satisfying in lots of children if you can make them better with that. If you look at the ear problems though, so the picture there is an eardrum, so that's if you're looking into an ear and if you have a really grotty ear infection before it's burst, that's kind of what it looks like. It's the sort of classic textbook description for us of a red bulging eardrum. It looks like there is pus behind that eardrum, and it builds up pressure, pain. You can be really, really unwell with it. And normally it's just like a spot or an abscess anywhere else. What your body wants to do is find the path of least resistance, and you can get a little perforation, you can get pus coming out, and it's amazing how much pus can drain out of your ear. A really small hole can actually lead to a lot of pus draining out. So that's the kind of infection side. That's what can happen, and you can have repeated infections. That's quite problematic if for no other reason for some people in the fact that it's practical things. You can't get back to work, so your child can't go to nursery because nursery won't take them with a running ear. There are lots of practical things, because actually your child might be very, very well once the discharge has happened. The second bit there is hearing problems. Okay, and this is a little bit more of a debate, because you can have gloom, you can have infection, you have all that stuff going on, but you may or may not have a hearing problem. And that again you can split down to, you may or may not have a hearing problem that we can look at and detect on a hearing test, but that still doesn't mean that your child will necessarily feel that they have a hearing problem. So it varies, and actually sometimes you can have really awful hearing tests. The child feels that they can hear absolutely fine, their speech is coming along leaps and bounds. It can be the other way around. You can have a really, really small hearing drop that actually can affect a child quite a lot. So there's a big difference. It doesn't necessarily marry up. There's no point in me telling you 30, 40, whatever in terms of numbers, because actually it's more important what your child is able to hear and finds is the problem. So hearing infections don't always go along. You can have lots of gloom, you can have lots of fluid behind your eardrum and still not necessarily have a hearing problem. So we do have to look at what the problem is rather than the things that we can find or see on tests. And grommets, as I say, it's a really simple procedure from our point of view. So from a surgical point of view, this is classic day case surgery. You come in, it's we would say it's a 10-minute operation, and you can go home the same day most of the time. It's a tiny tube. There are no scars as such that you can see. It's a small scar into the eardrum. So nothing that's visible on the outside, there's nothing that says you've had an operation done. And as I say, it's great. It's great for letting air and oxygen in. It's not meant to drain fluid. And I think that's one of the problems, is that people assume it's a grommet, it's a ventilation tube. That ventilation tube is the more accurate description. It's the air and oxygen getting in that is actually the thing that makes things better. If you're looking for it to drain fluid, that's not what it's actually designed to do. And if your body is producing mucus all through that area in the bit behind the eardrum, which all of our bodies are, but you can't clear that, then actually putting a grommet in, all that might be doing is just rerouting it out of the ear and out of the grommet. So you get all the stuff dripping out through the grommet, bits of oxygen getting in, trying to cure the process, but actually the mucus is just being redirected. And that's sometimes why you can run into problems with grommets. So hearing, gluvia, infections, discharge, all of these things can be made better. But it's, if I look at gluvia, okay, so if you look at all 2-year-olds as a snapshot at the moment, 20% of them have got gluvia. If you look at everyone going up to preschool, 80% of children will have had gluvia. And although it feels like I put an awful lot of grommets in, I'm pretty sure I haven't put grommets in 80% of children. It works really, really well. It's great for hearing and speech. It's less good in all children for infections anyway. And if you have PCD, it's still a very easy operation to do for us technically, but you need to be sure that actually it's gaining you something as a result. And if you end up having tons of discharge and effectively coming back into hospital to be dealing with that, that can be an issue. It's also, if you're looking to treat the hearing and you then get tons of discharge, sticky mucus that can then either block up the grommet or be pouring out of the ear, then perhaps if you're looking to use a hearing aid, which is very, very effective for hearing problems, they can be less effective if you've got a wet ear. So, there are problems that can come about with using grommets. So, in our department, we would say yes, it is something that can be used. We haven't found that all children have problems with discharge, but I think you certainly have to be having a very frank conversation as to, this might be the situation that it may not be the quick fix that you were hoping for. And if you're returning with lots of problems with, let's say, wet ears, then that can be more of a problem that you've found yourself having. For the hearing, it really depends on the hearing levels. If you've got a mild hearing level and children are doing well, they're interacting socially, their speech is developing, then there is a lot to be said for just monitoring that and having hearing and speech support in school. If you look at the educational sector, there are great advances in recognition of hearing impairment. So those kind of simple factors may actually be more effective. Hearing aids are great. Okay, they work very, very well. It's a problem when the hearing levels fluctuate, and you might have to have them adjusted. So you might be seeing your hearing aid technician more often. But it's not a reason to say it's not a simpler solution sometimes, and it should be something that should be spoken about, rather than someone just offering you grommets and a surgical solution. And then if we look at sort of nose problems, again, we've got lots of kit that we can use. Okay, we can stick, telescopes up people's noses and all sorts of things. So these can be done without a general anaesthetic. It's a very good way of looking up the nose and seeing what's happening. Obviously, it depends. It would be something that I could do in all of you. Actually, it's very variable what you can do with children. Some children are, you would expect not to be able to do it. You can't just base it on age. You do have to look at the child individually. That, I don't know if you can see it up there, but that's kind of a classic appearance of a polyp, which is that sort of grape, cysty kind of looking structure there in the nose. So this is looking with a fancier camera sort of into the nose. It's very, very rare in PCD, but it's not unheard of. More often you tend to get rhinitis, so just kind of the allergic process of the nose, and then you get the sort of rhinosinusitis, so or the kind of infection that can build up. The scan there, it's kind of looking, it's a CT scan looking this way through the body. The nose at the front there, and you've got the sinuses here, which tend to be the sort of biggest sinuses in all of us, and certainly in children. And the grey stuff there is the kind of the mucus kind of lining that you can get. It should all be nice and black. Black means air. The sinuses should have air in them. And then again, they're lined with, it's the same thing. So the nose all the way down to the really small bits of your lungs, they all have the same lining with a same hair cell cilia that should be wafting along and helping you out. And the sinuses effectively end up as a bit of a sump because there's mucus produced, there's mucus that can't be cleared away, and you get all the grey appearances on the scan when everything is sitting there. And gravity usually means that, especially in these sinuses, they sit at the bottom and collect. And anywhere mucus can collect, same as your ear, you can have just the kind of mucus on its own, but then you can get bugs on top of it and give you infection, so you can then have rip-roaring sinusitis needing antibiotic treatment. In terms of what we can do surgically, yeah, as I say, we've got sinus surgery kind of options, and what we do, again, in one sense, it's great because you don't have any scars. It's done through your natural nose opening, so we put instruments through the nose. You can leave as a day case. You go home the same day. You don't look like you've had an operation. But inside, what we would have done is effectively take away, I'm too short, sort of this section here, and this is the bit you're left with. So basically you've got a bigger opening to that sinus, which is great. It might help, and there are lots of reports that actually helps. It helps you with getting a normal treatment anyway. It helps because there's just a bigger hole for things to drain down. But if you kind of look at where that opening is, it's kind of at the top, so it doesn't always actually help, because you would still need something to try and move the mucus out the way, and gravity's still saying that it's going to be sitting near the bottom. So it doesn't always help for clearing the symptoms, but there is benefit in saying, well, if you have that, at least if you're then using your saline washes, which is lots of, goodness about saline, we're designed to be living by warm sea air. So saline rinses are perfect. But the saline can at least be sort of sloshed up there and help move it out. So it's actually providing that movement of stuff out with something saline, which is just something that your body would be very used to anyway, so there's no extra bits in it. So in terms of problems with the nose, yeah, again, snotty-nosed kids, I would argue is, kind of what I expect to see in my clinic. If you find a problem, and actually, so babies, actually there's lots of evidence that infants born with PCD have problems with their nose even very early on, and we're very bad at recognising. We look for all the complex things to do with your nose that might be causing those problems. And actually things like reflux, which is really, really common in babies, is the commonest reasons why you can have a snuffly nose as a baby. But actually, if that doesn't work, maybe we should be looking at other things as well. So it's part of me is doing this talk so that I also check, and we check within our department. This is, these are the kind of things that are being done, and are the neonatal team aware of these things? Again, we have lots of great options. Surgery, yeah, it's fine, it's great to do, but actually it's got to be worthwhile, it's got to work. It is an operation, it is a general anaesthetic. Something like sinus surgery isn't 10 minutes, it's not hours and hours and hours, but it's still a general anaesthetic. But you don't want to, no one should have a general anaesthetic unless you absolutely need it, but certainly if you're young, you want to avoid it if at all possible. And I think the thing with sinus surgeries is always, is it going to be worthwhile? Are you actually going to address the underlying problem? If you accept that it's maybe something that's just going to help with your treatment, and your treatment, say, like douches, that's fine. If you accept that it will help antibiotics or sprays get in, then that's great. But it's not going to cure or make the overall condition any better, because you still need stuff to move the mucus away. This is just the last slide, and I was asked about this just in doing this, and whether we should have a clinic here in Glasgow looking at sort of a multidisciplinary approach. And I presume that I know Anne Devaney is the respiratory physician for PCD. We don't have a dedicated ENT person for PCD. I would hope that Anne feels able to refer to all of us, and I'm sure she's received sort of referrals or queries from a lot of us. I think this is where I'd probably be more interested in your thoughts than on mine, really. I mean, obviously there's the whole health economics aspect of it. There are several conditions. Who decides which is the one that needs treated, which is the one that needs the multidisciplinary clinic? We feel like we run lots of specialist clinics. We don't have a cystic fibrosis link person for ENT. So we don't have a PCD person either, but cystic fibrosis is slightly more common, but that's not something that we have here. If you quickly do a Google search, and I know Southampton, for example, have a multidisciplinary clinic with an ENT person sitting on that. And I think the query came back because someone said, obviously the Brompton have started doing one of these combined clinics, and is there a plan to set things up here? I'm not aware of a plan. But that doesn't mean no. I think it's the kind of thing that we would probably chat to our respiratory colleagues about and see what the feeling was. And when you have these kind of clinics, what you always want to think about is how often do you need to see a patient? Is it something that's an annual check? Is it something, for example, I think the Southampton model seems to suggest every 3 months that a child is seen by every single speciality. I suspect you probably see your physiotherapists and respiratory physicians a lot more often than anyone from ENT, unless at the moment we're getting on a model where we just kind of, it's kind of ad hoc. We get asked, or we tend to ask the question. You may well argue that maybe we don't ask the question often or early enough, but I think that's equally an important role for us, is actually asking the question, because you may well be coming our way first before a diagnosis is actually made. There are some models that suggest neonates should be involved in a multidisciplinary clinic. I thought that was maybe a bit too early myself, but it's kind of where does a clinic stop? Which are the appropriate people to have in it? So maybe that's something for a Q&A forum if you are interested. I'm told questions, not now, but at the end.